My name is Lisa Hicks. I'm a malignant hematologist, but I also support a busy inpatient general hematology service. I see a lot of patients with many different blood diseases, patients I tend to meet when their disease is at its worst. Today I want to tell you a story of one of the patients I met recently. Let's call her Stacy. Stacy is a young woman with 2 children and career aspirations she's had difficulty realizing because she spends so darn much time in hospital. Stacy has sickle cell disease. I met her when she was admitted to our intensive care unit with her first ever chest crisis. Now, while it was her first chest crisis, Stacy was no stranger to hospitals. She'd been experiencing frequent pain crises for at least 2 years before we met. In fact, she'd had 3 visits to various emergency departments in the previous 6 months. Stacy had health insurance, a primary care provider, and moderate to high health literacy. She was an ideal candidate for high hydroxyurea, a drug she'd heard about but never seriously considered. Stacy is one of the faces of the gap between the ideal evidence-based care our patients deserve and the actual care that many of them experience. I bet many of you know a Stacy, or maybe you know a Carl with ITP, chronic steroid use, and numerous complications from the steroids he's taken on and off for years. Or perhaps you've met a Henry who experienced an intracranial hemorrhage on warfarin 12 years after he was diagnosed with a postoperative DVT. You don't have to be in medicine for long before the gap between ideal care and actual care starts to take on a human face. It has been estimated that it takes 17 years for a breakthrough in basic science to be translated from the wet lab to clinical trials to practice guidelines and eventually into practice. It's interesting, actually. Different studies, different methods, they all arrive at the same number, 17 years. But this is only the tip of the iceberg. Depending on the field and the practice change involved, it can take another 10 years for an innovation to be widely adopted by the medical community at large. This gap between the possible and the actual is the focus of 3 relatively new disciplines in healthcare: quality improvement, knowledge translation, and implementation science. These overlapping disciplines use different models, different terminology, and sometimes different methods, but they're all fundamentally addressing the same phenomenon. We have a gap between what we know is best care and what many of our patients experience. I'm here to convince you that we need to spend as much time and energy addressing this practice gap as we do on developing and testing new treatments and technologies. What is the point of advancing medicine if only a small number of our patients experience the benefits of the advancements we achieve? The problem is that changing practice is difficult. It's messy, it's multifaceted, and it's contextually dependent. It isn't clean and reproducible like a well-controlled experiment or a balanced randomized controlled trial. So how do we do it? Well, we do comparative research to identify the best treatments and practice models. We develop evidence-based practice guidelines to establish best practice. We disseminate knowledge of best practice to the broader community. We implement tools and policy to facilitate the best practice we've identified, and we measure, measure, measure. Today and throughout this meeting, you will hear about the ASH evidence-based practice guidelines addressing venous thromboembolism, ITP, and sickle cell disease. Guidelines on VWD, AML in the elderly, and ALL in the AYA population are coming. High-quality guidelines are a foundation to optimizing care. They help establish a standard and identify areas where further research is needed. Disseminating the guidelines involves spreading the word. For the guidelines, we do this through accessible online versions, through an iOS app, through publications, through education sessions, through pocket guides, through free teaching slides, and through regional adaptations. But what about implementation? Guidelines won't implement themselves. Implementation happens at the system, hospital, and individual patient level. At ASH, we're developing toolkits, decision aids, and meaningful quality metrics to aid in implementation. We're exploring CPOE-embedded decision supports, and we're advocating for change. But this is where we really need you. We need the energy and ideas of people like you. We need people passionate about providing the best possible care, people with new ideas, people who can help drive the change. On the tables in front of you, you will find sheets of paper. I invite you to share with us your ideas. How can ASH help to close the gap between best care and real care? What can we do together to help our patients realize the benefits of the science that this meeting is all about?